that part of the nail bed's not even active. So you could trim away half the nail and it won't bleed at all because it's detached from the underlying nail bed. And then there's a significant amount of debris. People don't realize what it is, but they'll see they don't know what it is, sock lint or whatnot. But basically, the fungus actually accumulates underneath the nail plate.
So when they have that fungus, so the nail bed doesn't bleed, but they're separated. Is that right?
That's why it doesn't bleed. It basically is devitalized, or poor tissue that's just not allowing the nail plate to reattach to the nail bed. So when you treat, that's the goal. You want that nail plate to reattach to the nail bed and then grow out from there. The reason why...
So the tissue in the bed is kind of like falling off, sloughing off?
Exactly.
That's what you see in the person. They see that stuff?
And the reason why most of the products will not be very effective, especially the over-the-counter products, is because they sit on top of the nail. The fungus is what's underneath the nail. So you actually need a medication. If you're going to utilize a topical, you're going to need a medication that's actually going to penetrate through the nail plate so it could get underneath into the nail bed. If you're not doing that, you're not treating it. And that's why these medications don't work.
What about the ones that you take by mouth, orally, the ones you see on TV, and then they tell you have to have blood tests and stuff like that? What's that medication like? Does that work?
Well, also on TV, you will see one of the topicals that will penetrate through the nail plate. And that one's Jublia, which a lot of people might be familiar just from their marketing and advertising. But the problem with Jublia is that they recently come down a little bit in price, but that price was $1,200 for one bottle, and you need about
really?
6 bottles a year, one every 2 months. So we carry something in our office that goes head-to-head with this medication for a fraction of the price, so it's very affordable. And you don't need to spend $1,200. Ours runs about $75.
So how do you decide whether you're going to treat them topically or orally or with a laser? So what's the difference?
Probably the price component's the biggest difference. I would treat everybody with laser if I could. It's the most effective way of killing the fungus directly. But the price is cost prohibitive for some people. And it's not covered by any of the insurances.
I was researching a little bit of that, and some of the reason is that a lot of the insurances, and one of the things I always say is insurance companies are in the business of not paying, even when, and they consider that sometimes some of the insurance companies, which I really find I'm at fault with, is they consider that to be cosmetic when it really isn't cosmetic at all. It doesn't look great, but it really is a problem. So anyhow, if I had that problem, I know that I would bypass my insurance company. I do that for a lot of things, bypass mine, because it's your health. Is there a downside to not treating a fungus nail?
Plenty of potential complications you could have from fungus nails, and it also depends on comorbidities, what other health issues you might have.
Diabetes.
And diabetes would be one, because with diabetes, and many know it can affect the nerve function, it can affect circulation, but in essence, fungus nails, the deformity of the nail can lead to bone spurs, ingrown nails, infections. So it sounds to me like it's more than cosmetic. What I was also thinking is that I know that fungus, because everybody knows what that is in orthotics. So I'm going to give out our phone number because I'd like some people to call in and tell us what they think about their experience when we get to orthotics or even before, and what they think about what is fungus nail. So the number is, Dan gave me the number again, 845-331-9255. 331-9255. Feel free to call in. So back to the fungus. With all those comorbidities, which means other problems, such as diabetes and high blood pressure, and different problems that people have, along with having a fungus nail, it increases the difficulty. Like you said, they can end up with bunions and other things because their foot isn't right, or how does that work? Does the toe become malaligned, or the toes become malaligned with fungus? I don't know that. No, they don't.
Good.
The nail could become malaligned, but not the foot. Most of the foot issues.
I meant the toe.
Most of the foot issues that you're referring to is typically biomechanical, which typically means hereditary. There are certain things that precipitate things of whether it's going to hurt, whether it comes up in teenage years, whether it comes up in adulthood. Everything from one's activity, do they do sports, are they overweight? All these things, pregnancy, all these things can precipitate these deformities earlier than others.
I don't want to get off of fungus, but I was just thinking of something. When I was younger, I used to wear a size 10 shoe. Now I wear a 12. Is that because I've been on this earth too long, or what? Or did I not have the right shoes on?
Well, I'm right with you. I used to be 11 and I'm a 13. So
What happened, doctor?
This is also a great point because people have no clue. They think, once they're 16, they're done. They're never going to need another shoe in their life. The problem is the alignment of the foot changes based on flexibility, ligamentous laxity.
Wait. Alignment in what?
So let's just say you have a high arch.
Okay.
Okay. So you have a high arch and you're a size 11. Now your foot starts giving. So think about your foot giving out. It's going to get longer and longer. All right. And also it can splay, meaning the metatarsals splay, such as when people get bunions and on the big toe and tail bunions below the little toe. Those are things that are going to make the foot wider. So as your foot gives, the higher arch you have, the more potential you have for it to get a larger size.
Oh, so it maybe didn't grow, it just fell down
It
or gave way.
It didn't grow at all. It's just a collapse of the loss of
Arch.
integrity of the arch.
And then your foot flattens out,
Yep.
and then you have a wider foot. So I went from a 10D to a 12 triple E. Now I'm just kidding.
Congratulations.
It's hard. I'm very interested in this topic because it seems that I can't find a shoe that works for me. And as I mentioned to you the other day, we were talking, is if I go try on shoes, and I'm only good for about 5 pair, and then I'm done. I can't do anymore. It's sort of like if somebody said, try this cologne and that cologne. After 2 sniffs, I can't smell anything. Well, it frustrates me to try on shoes. So what I do is I always put my left shoe on first. Everything fits my right, but not everything fits my left foot. And so I'm saying, I got 2 different feet here. I know I got 2 different feet, but 2 different sizes, and most of them aren't comfortable. What's that? Why are your feet different sizes?
Well, typically you're going to be at least a quarter inch between the 2 sizes would be kind of average, but it could be a lot different than that. And then if your foot's collapsing more on one, maybe even from an injury or just instability, or you develop a bunion on one, you're definitely going to be 2 different sizes. So you're finding the easy fit first. The trick is, and I have a few patients that are just really forced to buy 2 pairs of shoes because they can't wear the same size on both. That's not common, but it happens. And if they're having issues and problems, or they're diabetic who are prone to ulcers and things of that sort, then it's a necessity that they have 2 shoes.
So your foot isn't just the foot we see. It's a foot with a lot of different sizes, situations, complications, bunions, and now fungus. Back to fungus. For some reason, I find this to be really interesting. Because first of all, it's not great to look at. And I always think, when I think about fungus, I always think about these women who love to wear open-toe shoes or flip-flops, and they must not be able to wear those things. Or they're probably embarrassed to wear them. I don't know. What happens, listener? Anybody have this problem?
So, yeah, that's a big concern. And probably the number one complaint of the fungus nails is the cosmesis and the embarrassment. And that's why we have things like the laser. It's not found everywhere. We use the pinpoint laser, which is the number one laser. It also only needs 1 treatment, where other lasers need 3 treatments. This is the one that the FDA first looked at and cleared. This is the original laser. And I actually discovered this at a conference out in California. I was trained in California for this procedure and was the first one to bring it to the East Coast.
Really?
Yeah.
You're a real innovator.
I love it. I love it. Yeah.
So
yeah.
what does a laser do? I mean, you wind it over their toe, back and forth? What do you, all the toes, one toe?
So obviously we concentrate where we see the fungus, but all the toes need to be treated because there's cross-contamination throughout the entire foot. And it's even more than that. Fungus is fungus, so this is the same organism that would typically cause the athlete's foot, which is the fungus infection of the foot. So, and that's a skin infection is the athlete's foot. So the skin cross-contaminates the nail and vice versa. So even when we do laser, we will also dispense a cream to put on the foot for a couple weeks. The skin fungus is a lot easier to treat. The nails are a chronic situation, but skin typically you can clear in 2 to 4 weeks.
So when we have the nail fungus, you got to get it someplace where, like the gym. Where do you get this stuff from? You just can't.
That's the most common place, and just because I always tell my patients, if you're going to use a public shower, make sure you at least have flip-flops on in the shower and avoid barefoot at all cost. Not only can you get fungus, but also that's a common area where you get plantar's warts as well.
Really? Yeah. Boy, that's terrible. I'm afraid I don't shower at the gym anymore. I just go home and shower.
That's a good move.
Probably for that reason. I mean, I don't like flip-flops. I can't wear them. They hurt my toes. But I just know that's not a good thing to do.
I do want to mention, because you brought up the embarrassment and the cosmesis. So something else we do at the office, and it's not commonly found, but this is another thing I had researched and saw at the learned through my conferences as well. There's something called KeryFlex, and the public can look this up at KeryFlex, and that is a cosmetic treatment that's an antifungal polymer, so it protects the nail against the fungus even while it's infected, and rebuilds the nail immediately, and you will have what looks like a near perfect nail, if not a perfect nail, immediately, and it'll last about 4 to 6 weeks. So if you're going on holiday or you go into a wedding, you could have a perfect looking foot, and you could wear the open toe shoes and the sandals.
Is that right?
That is right.
Well, that's cool. That's good to know also. As I said to you when we first sat down, that I, for some reason, when I was doing my little research that I like to do, I found out when we're talking about laser, I didn't know that laser was an acronym. And so I just found it and I just lost it. The acronym. And what it means is light amplification by simulated emission of radiation. That's an acronym that's what laser means. The light amplifications by stimulated emission of radiation. How's that? So I just thought laser was laser all these years. But
yeah, and there are different types of lasers. There's ultraviolet, which would be super effective to kill just about everything of fungus related. But the only problem with the ultraviolet light is it's carcinogenic, which basically means it could give cancer. So we don't use UV light. We use it's infrared light that we use. It's an invisible light. And it emits through the nail plate, so we don't have to do anything to the nail. It will go right through the nail plate and hit the nail bed, which is where the fungus lives.
They wear goggles or glasses?
Absolutely. We have special glasses for that, 100%.
So after you treat them, isn't there a way to also treat their shoes afterwards and keep it?
Yes. In fact, we do dispense those as well through the office.
What is that?
And it's basically looks like a shoe tree, but that is ultraviolet light because we don't care about killing the shoes. So we want to kill everything in the shoe, and that is super effective. It'll kill. The studies show 99.9% effectiveness to kill fungus and bacteria and viruses, just everything in that shoe.
We use that too for equipment that we use to clean ears with and probe ears and stuff. Yeah, so I think that's important. So on the fungus situation, does insurance cover this?
For the pinpoint laser, like we discussed, they don't. That was one of the downsides in being cost prohibitive for people is that the insurance companies will not cover that, and that's where we go with the other treatments that we discussed.
That they do cover. Well, I think it's important that people are comfortable with solving their problems, and also the cosmetic aspect of it, which really isn't cosmetic to me, but I'm sure it's for most people who have fungus. Let's talk for a second, if we can, please, about orthotics. I tried orthotics myself once, and for me it was hit and miss. And so I know that there's like stuff you can buy at the store, Dr. Scholl's inserts, and I guess you have those are inserts, and you have orthotics. What's the difference? How do these things work? And what are they for?
So custom orthotics is my passion, and that's what I specialize in my office. And in fact, I even lecture to my colleagues several times during the year throughout the country on this very subject, because it is so underutilized and very often not utilized correctly. And I'm there to help our profession give the best orthotics possible. I think the difference between a custom device and an over-the-counter device. An over-the-counter device, you're basically buying an arch support. A custom orthotic, I never use the word arch support. It's not an arch support at all. It supports the arch by default. But what a custom orthotic does is it realigns the foot into your best alignment. So everybody has what we call a neutral position, which is an optimal alignment of the rear foot joint. And that can be palpated, meaning felt and positioned.
We're going to take a break, but I want to get back to what realignment is and how that works, and does it affect your knee? Does it affect your hip? Does it affect your back? So we can come back to that. We're going to come right back. Thank you. We're back. I'm with Dr. Tracy Toback. He's here in Kingston. He's a podiatrist, and we're talking about all different aspects of the foot. And we left off with orthotics and alignment or realignment. So a little more in depth, you were talking about, the orthotic and what it does and how it's not just for arch support. Tell me more, please.
So the primary reason that people end up with the multitude of foot problems out there, and that includes everything from hammer toes, bunions, heel spurs, arch pain, plantar fasciitis, the cause is improper function, which you could relate to mostly hereditary, but a lot of things also precipitated that we discussed before. So an orthotic can prevent and treat those issues primary by controlling the function of the foot so it doesn't, whether it be collapse on you or a high arch, which loses a multitude of shock absorption. So it basically will optimize the function of the foot. Same way eyeglasses will get you 20/20. I mean, you can compare an over-the-counter maybe with a dollar pair of magnifiers versus prescription eyeglasses, which will actually put you at the 20/20 vision. Same thing when they talk about neutral position, optimizing the alignment of the foot, which is really important, which is why when I do orthotics, and I encourage all the doctors to do this, is to cast yourself, because that is the most important component.
You mean cast the patient?
Yeah, so what we do is we actually make a custom cast. It only takes a couple of minutes. I use a slipper sock made of fiberglass, and it actually dries in 1 to 2 minutes.
Step into it
Nope. You never step into something, and that's a mistake many doctors make too, because they have these foam impressions. And if you look at the foot, I mean, I've had feet that look like a tremendous high arch, and when they step down, they collapse into a pancake because it's so flexible. Well, the last thing you want to do for a high arch foot is just to make a pancake device. So you're not capturing neutral at all when you're putting your foot down and just weight bearing. It needs to be held.
How do you get neutral?
So I have them off weight bearing, and I position the foot. I will find the neutral. I have my assistants help too, so we pretty much use 4 hands to do this right. So I will swing the foot into neutral in the rear foot, and then I'll load what we call the lateral column on the outside of the foot in the forefoot region, and that will give you the optimal arch that your foot will be able to tolerate while maintaining the neutral position.
Okay, that sounds really good. I have no idea what a forefoot is.
Forefoot is
so
the
you lay
end
them
of the
down.
foot.
You lay them down.
No, yeah, they're sitting in the treatment chair, and the foot's overhanging the ledge, and I will cast and position.
So you put the cast under them, and they don't step down on it.
Nope.
You just put it and form it to them, and your assistant help. That's why the 4 hands.
Yep.
They help you, and it takes a couple of minutes, and then you get a cast. And what do you do with it? doctor?
We admire it.
Oh,
and
good.
we let the patients know what a great impression they just made. And then we send it to a lab. It's one lab that I've used that's one of the original founders of the art of orthotics, and I've stuck with them for years. They make a fabulous device. I always tell people and my colleagues that the orthotics is only going to be as good as the cast you make, the prescription you write, and the lab you use. Because if you don't have those components, it's garbage. So that's why I will have people walk in with bags full of orthotics, and I still tell them I got to make them an orthotic because that's what they need.
Okay, so is the orthotic soft? Is it hard? Is it like a plastic? What does an orthotic look like?
So they all look different, and that's what I mean by custom. I know there's certain professions out there that make the same device for everybody, which doesn't make any sense at all. Every foot is different. What's the age of the patient? What's the activity of the patient? Are they involved in sports? Are they involved in any specialty sports? What is their foot problem? So every orthotic is different. Am I making a sport orthotic? Am I making an accommodative orthotic? Am I making a walking orthotic, a geriatric orthotic? They're all going to be different based on their activity and based on their foot issues. So that's why I in that how to make the perfect orthotic in there was the prescription, and the prescription is the type of device.
I did have an orthotic once. I did the Dr. Scholl's thing, and I have something on my heel right now that I use. It if I don't use it, it doesn't. My foot hurts. But when I had the orthotic, it was like a piece of plastic, and it hurt the arch of my foot. Something terrible. I could walk for about 10 minutes. I'm done. It was painful as heck.
So think about that. So yes, most of our orthotics are firm, especially if you're a runner and you need to control that. The orthotic that you describe, if it's something that's firm or what you described as plastic, just think about it. If it's not made perfect, it's going to hurt you. If it's made perfect, it's going to fit like a glove.
It's amazing how sensitive feet really are when you think about it. Your hands can tell what's going on. You can tell little bitty things from your fingers, because it's a lot of nerve endings, but I think your feet must have the same situation because, if I step on something really small, I can tell. People have, feet that they can walk on fire. Me, I can't walk on anything. My son walks around with barefoot, and I just can't do it. I have to have a shoe on all the time or a sock on. My feet don't like being out there. There's a lot of nerve endings there.
Oh, yeah, and some people's feet are super sensitive, while others are fine. Some people will develop more diffuse callus based on their foot type, and they don't feel much at all, so they could just walk on, some hot coal and be fine. I don't advise that, of course, but yeah, every foot is
Tony
different.
Roberts like that. Get you all excited. You can walk on fire. Yeah, right, Tony. Anyhow, so there is a real difference between how people think of their feet, how feet work, how foot works. Is there a relation between your knee, your back, and your foot?
Yes.
Good, thank you. That was a good question. Thanks for that short answer. Tell me why.
So when I dispense an orthotic, I do not allow them to wear it all day. I do not allow them for the first week to do any activity that would be considered their sport or their exercise, whether it be walking or running. And that is not so much we go through a break-in period, but that whole point of the 1 week is not so much for their foot to get comfortable, it's for their whole body to get used to that new position. The foot's your foundation. When the foot's off, everything has to make up for that. If you're losing shock absorption, the shock has to go somewhere. It's going to work its way up the body. Ankle, knee, hip, lower back, shoulders, everything gets affected. So when we do orthotics, we take it very seriously, and we have them break it in. Sometimes they'll put it on and feel great, and we still let them know they have to go through the full break-in for that reason that you mentioned.
So you go from malalignment to realignment.
Yes, there you go.
Thank you. We do this. I do the same thing if somebody wants a hearing aid. I tell them it takes 30 days to wear it full time, and we start with a couple hours at the end of the day. For us, I don't put a hearing aid on a patient and send them out the door because it's all noise. Mm-hmm. And they hear better, but it's all noise. So we put it at the end after they eat, 2 hours, like from 6 to 8, and then we go 6 to 10, and then we back in 5 to 10, and we back into the day. So it takes, but it also takes 3 to 6 months to adjust neurologically to your hearing. Otherwise, it's noise to your ear. So that's why people reject hearing aids. A simple thing like that.
Sure, makes sense.
And all of our patients have to have a wearing schedule, just like with orthotics. And I don't think people realize that there's a neurological alignment or malalignment when you have a hearing loss, just like there's a structural malalignment with your feet to your back to your shoulders. How's that for an analogy?
I love it. I love it. You're right on. I appreciate it.
I think that's one of the things that people, especially practitioners, sometimes fail to see with patients. We do stuff with patients, and then we expect it to be okay, no matter what we do. Like you're done. You walk out. Like with cataracts, you can do that. Boom, really looks good. You can see. You're not blinded anymore by bright light. But there are a lot of procedures that people do, like your knee, if you have surgery on your knee, replacement of your hip, that you just don't walk away. And that's why therapy is important. But I don't think we ever talk about going slow and why it's important to go slow because of the, quote, malalignment of the body or the balance system or whatever. Oh, thank you.
Sure thing.
So we did the fungus thing and the laser. I like that laser idea. I was reading about the laser, and I saw some pictures and some movies on it. It really works pretty well.
Yeah, the success, as far as patient satisfaction, I would say is about 80%. And it varies because this particular pinpoint laser through the infrared laser beam will kill the fungus, but the nail bed still has to repair on its own. And the nail cosmetically only looks as good as what it's growing on, which is the nail bed, which is damaged. So even though we could kill the fungus, one, we have to stop new fungus from attacking, and two, the nail bed can take quite a time to heal depending on the severity, how long you've had it, for instance, and how bad it actually is.
So once you treat it, the nail has to grow out. So it isn't like it's just magic and it's clear. It has to grow out and then fall off, and then the new nail's coming behind it. Is that how it works?
You're describing it pretty well. The only magic treatment I have, even though it's temporary, is that KeriFlex. So we've even included the KeriFlex now when we do the lasers, so they get a real excellent feel-good feeling, on the way out.
KeriFlex again.
KeriFlex is that cosmetic antifungal polymer, which will, because some people have half a nail with the fungus. Some people have barely any nail. And this will just attach right to the remaining nail plate and fill it all in and make it look perfect.
Oh, cool. Like I don't know what it'd be. A new nail.
Yeah, no, exactly. We have some people will come every month because they just love it that much.
Is that right?
Yeah, and then they just want to, they wear open toes, or they just go in places
until it grows out.
Well, yeah, until it grows out. I mean, typically most people go at least like 2 months, but I have people even go every month because they want that fresh look.
Cool. So what's that? It's like a nail salon for feet. One more thing I was thinking about is when we were talking about orthotics, you mentioned the word hammer toe. That sounds really interesting. Does that mean you hit your toe with a hammer, or your toe looks like a hammer? Or what's a hammer toe?
So hammer is the expression when the toe's actually contracting. You might see the tendons bowstring. You can see the toes pull back. But when you have the toes cocked up in the air somewhat, you're describing with your finger very well at the moment. Yes, and that's referred to as a hammer toe. And that's the cause. A lot of people may have what we call corns, is a generic term, where they have excess dead skin on their toes. They could get very painful. We do have people come for palliative care. We'll actually debride or shave those down, and it will give immediate relief. Those are one of those things I talk about when they limp in and they leave, seconds later and feeling great after they've suffered for months or sometimes years. But yeah, the cause of those corns are typically hammer toes.
So is a hammer toe a result of a tendon pulling back on the toe? Is it a tendon problem, or is it what is it?
Ultimately, it is a tendon issue, but the cause is functional, same as everything else.
No surgery for hammer toes?
Oh, sure there is. Sure there is. So we do everything I'm talking about. There's surgical components depending on the severity, the person's age, their activity. But hammer toes can be corrected. It's a common procedure that we do.
Another topic I think that you guys deal with are warts. They call them plantar warts and stuff like that. What is? I know what a wart on a hand looks like. What's a wart on a foot look like?
So actually, it's similar virus. It's the human papilloma virus. A lot of people don't realize that these warts are HPV viruses. What also they don't realize is that there's probably 200 variants of the HPV virus.
I think that's important, so people don't panic over this. When you say HPV, it doesn't mean cancer immediately, and it may be, you may be able to spread, but it doesn't cause anybody to have problems cancer-wise. Like 3 of those that are cancerous, and the rest of them are like this, a plantar's wart.
Yes. So we're talking about the variants in this case that cause the plantar's wart. And plantar just means the bottom of the foot. So it's a wart. The location's on the bottom of the foot. A little more difficult to get rid of than when you talk about the hand because the skin is a lot thicker on the bottom of the foot. So that means the virus is that much deeper. But the interesting thing is it's an epidermal virus. There's the epidermal layers of skin, and then there's the dermal layers of skin, which is the deeper layers. And this is only in the more superficial layers. But when it comes to the foot, it can be quite large and quite deep because the epidermis is pretty thick in the bottom of the foot.
So is it painful?
Well, location. So they can be very painful, and it depends on exactly where it is. Is it under a weight-bearing bone? You're going to feel a lot more on the heel with the impact of heel strike. It can be very painful as well. Underneath the large toe or, at the plantar or bottom of the foot, in the ball of the foot, on propulsion, you could be very painful as well.
So how do we treat this? Do we treat it with a topical, or do we treat it with another therapy? How do we treat plantar's warts?
There's a lot of treatments to warts, and many don't work. So it becomes quite frustrating, especially when you see someone come in that said they've had it 5-10 years and there's multiple warts on the bottom of their foot. But this actually got, over the last several years, it actually got a little more exciting because we found a treatment that works like 10 times better than all the rest. There's a new treatment called Swift microwave therapy. And this is a treatment where previous treatments and chemicals that we used, patients would have to come every 2 weeks, sometimes for a year to get rid of these. And now we have a treatment that typically will take 3 treatments a month apart and is super successful.
So that's a microwave treatment? So we got a laser, now we got microwave.
We got microwave, okay? And just like, the microwave in your home generates heat, this generates heat as well, but it's a pinpoint applicator right on the wart, and that generates the heat protein that stimulates the antibodies to fight off this virus. So it is a virus that our body typically can fight, which is why people say, I had a wart for 2 years and one day it went away. The problem with waiting on warts is, 1, they can get painful, and 2, they can multiply and spread. So I don't suggest just waiting on plantar's warts because of that, and they can, cause other issues too. So having this treatment is not a destructive treatment like the rest. This one is something that stimulates your immune system to generate the antibodies and decloak the wart, be recognized by the body to stimulate these antibodies and fight off the wart. And something else that's very interesting about the Swift, and the studies aren't long-term enough to tell you how well this is, but based on how this is, the technology of how this works, and stimulating the immune system, there can be a permanent immunity to these warts because now your body has now recognized the virus.
So maybe, just maybe, it going forward, you'll have your immune system will take care of the wart or the virus itself. That's pretty cool, as opposed to burning it and putting chemicals on it and stuff like that. Yeah, because the only thing I ever heard about warts was to use a chemical to burn it, And I remember in the old days, the pharmacist should have mixed the stuff up.
Yeah.
And you just pinpoint it like a little dropper, put it right on it.
Right.
Shh.
A lot of these treatments, though, they cause pain, they cause blistering. You may have to keep it dry. Some you have to keep dry 24 hours. Others you have to keep dry an entire week. So it definitely affects a person's lifestyle. Where with the Swift, there's no pain afterwards, and there's no bandages, and there's no restrictions. You swim, you get it wet. This is really revolutionary type treatment here. So we're excited to have this technology.
And so you think, again, how do we get this? How do we contract it? Is it back to the gym again, or what?
Back to the gym, the schools, they don't recognize it. Parents don't recognize this. I say parents because I want to tell the parents that kids don't get calluses, and they just think it's a callus and that it'll go away or it's not a big deal. When you see a child with a callus, first thing you should be thinking about is plantar wart.
Is that right?
Yes.
I didn't know that. So children don't get calluses, and if you see that, they should be looking at. They should be seeing their physician or coming to see you guys. I never knew that one. That was an eye opener for me.
Yeah.
So the microwaving is 2 or 3 treatments. And again, insurance, do they pay for it?
So it's that crazy answer of no. The reason being here is because there's no coding for non-destructive treatments of plantar warts. So if you're not killing it, you're not doing surgery, you're not destroying it, stimulating the immune system is not recognized.
That blows my mind to think that if you're not doing something destructive, if you're not removing tissue or cutting somebody or burning somebody, we're not going to pay for it.
That is correct.
And what's that? He wants to say something. See that?
Yes,
Here he comes.
thank you, Doctor. It seems that the Swift system has a lot of legs. It may be applicable for many things. If it's stimulating the immune system for our bodies, there may be other things other than plantar warts that it could be actually applied to.
So that's very true, and you bring up a good point. It just it has to be studied what it can do to stimulate the immune system. So yeah, and that was my one of my first thoughts too. Right now, they're actually seeing what the applications are for even fungus and fungal nails. So they want to see how the Swift works on that. And there's clogged sweat ducts that people get on the bottom of the foot that's not necessarily viral. And they've had a lot of success already with that. So the company they're out in Scotland. This technology's out in Europe, and they are constantly working on seeing how far this can go. So
That's how things work. Sometimes we find it works in one application, and of course, there are other opportunities. So you're right, Dan. Thanks for that question. Thanks for the call in, Dan.
My pleasure.
And again, speaking of call-ins, our number here is 845-331-9255. If someone wants to find you in your office, what is your phone number, by the way?
So it's 845-339-FEET, which is 339-3338.
Well, that's pretty, of course. Feet.
And then everything we're talking about, these treatments, it is on the website too. So I do invite you to see the information there as well, which is tobackpodiatry.com.
How do you spell Toback?
T as in Tom, O, B as in boy, ACK.
So of the things that we talked about, I know you say your specialty is really orthotics. You like that? That's your passion is orthotics?
Yeah, because it treats, like one of the most common things I probably see walking through the office is heel spur pain. They've tried treatments. They often try and treat on their own. This is one of the most common things people try and treat on their own. So by the time they come in, they've had this for months or over a year. It's not uncommon. So the reason for heel pain is typically heel spurs, and plantar fasciitis is also a common term, which is a very common sports term, but basically that refers to arch pain. But it's also synonymous with the heel spur pain because the plantar fascial ligament attaches to the heel, and the point where that fascial band attaches is exactly where the pain occurs, the spur occurs, the bursitis occurs, potential scar tissue occurs. And number one treatment, and probably about 90% successful, is custom orthotics.
That's amazing. So when people, my heel hurt once, and it was pretty painful. I think I jumped off of something and kind of bruised it or something. I was like, I don't know how people stand that.
Right, it's painful. I've had it myself.
Yeah. So you kind of, you kind of limp around for a while, and it's hard to put your foot down. And yeah,
Sometimes you have to put your foot down.
of course.
You know?
That's how I feel like that. I do that a lot. I put my foot down. So when we talk about orthotics, I was also seeing something both on your website and also I was researching it on a shockwave treatment. You know, it's like, wow, here we go, another one, a shockwave treatment. So if you're using orthotics, and then there's this thing for shockwave, you know, which comes first, a shockwave treatment? Well, let's talk about what that is first. Or orthotics or a combination thereof.
So my last statement was that orthotics are about 90% successful. So the question is, what do we do with the 10% that it is not successful with? So after treating for about 6 months, which will be anything from nonsteroidal anti-inflammatories, possible injection therapy, custom orthotics, if that person fails to resolve, my next step is shockwave.
When you do a shockwave, what are you treating? You're treating their toe, their heel, or their...
There's 2 points that I use shockwave for. That's basically heel spurs, but heel spurs could be at the bottom of the heel, which is typically the plantar fasciitis pain, or it could be behind the heel, which is the Achilles tendonitis pain. Just like the plantar fascia, the Achilles tendon, you can have tendonitis of the tendon itself, but it also inserts to the heel. And right at the insertion port, so shockwave therapy is for treated for tendon insertions. So that could be like elbow pain as well. But in my case, you know, it's going to be either the Achilles tendonitis or the plantar fasciitis.
Okay, so we're talking about where it is and what is it? A shockwave is like. You know, I'm thinking of TV program. You see this shockwave come across from the ocean or something. What's a shockwave?
So this is ESWT. It stands for extracorporeal shockwave therapy. And this is just high energy. So there is low energy shockwave, which you may have read about as well, and this high energy shockwave. Low energy shockwave needs several treatments, and the success is at best 50%. The high energy shockwave, there's several different types of machines out there, but the one particular machine that has the best studies and the best results is what I use, and it's a high energy shockwave treatment. It's one treatment, and it has about 90% plus success rate.
So when you think of a wave, you know, it kind of like goes up and down and around. It's an acoustic wave, right? Does it have sound?
Yeah. Well, you hear the sound, but it definitely has penetration power. So what it's doing, it's a minute. So the reason why shockwave works is what we're really treating, or maybe why those other treatments don't work, is there tends to be a lot of scar tissue. Scar tissue is a lot of non-viable, poor vascularity tissue, meaning poor blood supply. When you have poor blood supply to a tissue, it's not going to heal very well. So this is pretty much the cause of what we call recalcitrant, or difficult healing of the heel spurs, the plantar fasciitis, the bursitis. So what shockwave actually does is breaks up that scar tissue.
Okay, we're going to talk about how in a minute because Dan's giving me he wants to take a break here now, right, Dan? Okay, then we'll talk about shockwave. I have a couple of questions on shockwave.
Sure.
Back to you, Dr. Toback. We're just talking about shockwave treatment. Heel spurs, is that what it's for?
Yeah, so
What's a spur, by the way?
So heel spurs, well, all spurs are different and caused differently for different reasons. But in this case, body reacts to stress by laying down new bone cells. As you know, osteoblastic activity, it builds new bone, and that's what happens when you break a bone. Your body knows to heal it through this osteoblastic activity. Any kind of stress is no different. In this case, it's more micro stress when the fascial band is over pulling because the foot's either pronating. This is what we talk about with function. That's why orthotics work so well. So if we could control the collapse of the foot, we'll stop the pulling of the plantar fascia. So micro trauma day after day after day causes the stress reaction, which forms the spur.
So you're saying microtrauma, you mean a little bit of trauma every day on one point on the foot will cause it to swell or build a spur, which is like a bony thing?
It is a bony thing, but I mean the good news on this case is the bone itself is more of a symbol of what's going on, but it's not the factor that's causing the pain. What's causing the pain is the inflammation around it, the inflammation of the bursal sac, the pull, or the inflammation of the where the fascial band attachment is, and then ultimately scar tissue can develop.
It just hurts me just talking about it. Off air, we were talking a second ago about the shock wave. So the shock wave really is an acoustic wave. So it's a wave form, and you put it on somebody like a pulsating thing. Maybe is it pulsate?
Yeah, and we give about 3,000 shocks during this treatment.
Yeah. So you put it on the heel, and it's vibrating, and it's going to where the spur is, right? Does it break down that spur? What's it do? Does it break it down?
So no, it doesn't. It doesn't break the spur down. So we're not addressing the heel spur. Again, it's not the actual spur that's causing the pain. What's causing the pain is the scar tissue around it. What it does break down is the scar tissue. Okay. And basically, what you're doing is you're taking a chronic situation, a non-healing situation, because of the poor circulation. Associated with scar tissue. So we take a chronic condition and we create an acute condition. And now we have set up a scenario where the body can now heal itself.
Okay, so we're taking these pressure waves and we're delivering mechanical force to the tissue, if I got it correct. So we're sending this pressure wave in, and it's I almost see it like massaging around and breaking it up or something like that to treat it. Off air, we were talking about at least I was talking anyhow, about a fundamental frequency. A fundamental frequency, again, for listeners and for people, is there's a fundamental frequency of your voice. There's a fundamental frequency of the body. And there were studies years ago, if people were driving and they were driving down the street and they were going by these trees, and the trees were spaced, and the sun was coming from the east, let's say, comes up in the east, and they were driving, and they were going by, and as they drove by at a certain speed, not too fast, not too slow, with the right speed, the people would almost like zone out and look like a petit mal seizure, and they would crash. So some of these streets had more accidents than other streets, and then in the evening, it would happen again in the west when the sun's going down. Isn't that freaky?
That's crazy.
Yeah. So you have a fundamental frequency in your brain that makes people go, like having a little mild seizure or space out, and they lose control of their car, and they would crash. Isn't that interesting?
Yep.
So there's a fundamental frequency, and I was mentioning to you, your voice has a fundamental frequency, and Dan likes this because he's a music guy. He likes frequencies. And so your voice has a frequency, and your frequency is at rest, and you just make a sound like that's the frequency of your voice. So if you talk like this, that's not normal. See, so you help people with voice problems to bring their voice down by, first of all, finding that frequency. So back to your treatment. I don't want to steal your show, but to go back to shockwave. I don't know this, but when your guy comes back next time, why don't you ask him, say, what is the frequency, it'd be kind of interesting, of the shock wave? We know that it has a certain intensity level, because you can make it stronger or less strong. Didn't you say that? How do you do it?
Yeah, there's settings based on what tissue we're treating. For instance, you don't want to cause too much trauma to an area, so the way we treat the Achilles tendon is going to be different than how we treat the plantar fascia. So we make those adjustments.
Adjustments in what? Of the loud?
In the intensity.
Intensity.
Yeah.
Intensity.
Cool. That's really cool.
Maybe there's a multiple frequency range. Also, there might be 3 frequencies involved. And ratios of them, perhaps.
So do you set? He's trying to say, do you set it for, the heel, and then for another part of the foot, do you set something? I'm going to do the heel.
Well, and we'll gradually put it up. Sometimes it's the patient tolerance, but I do give a nerve block in the office.
Oh.
So because of high energy, and for patients who think they may have had high energy, if you didn't get a nerve block, you didn't have high energy.
A nerve block does what?
It numbs the foot.
Okay, good.
Okay.
So it's when we say shock wave, we want to make sure that they understand how intense it is, and yeah. How
There's
many
a big
people
difference.
does insurance cover this one?
No. Some insurance, we always do check because some insurances may cover a portion, but for the most part, it's a no.
So, do other practitioners understand these things? I mean, you know, I used to lecture at the medical staff. Do you ever go to our medical staff and I know you're on staff. Do you ever lecture to them about this stuff?
No, we didn't. Well, I think there was one point years ago where they actually had a machine in the hospital, but then it went away. The problem is shockwave is lithotripsy. So it's the same way you're breaking up kidney stones. It's just a different machine, a larger machine, you know, for that. But this is not really new technology. What's new with this is that it can be scaled down to treat the heel. The reason why it's so hard to find is because the insurance companies initially did cover it, and then they all stopped. For no good reason that makes any sense, and because of that, a lot of the companies bailed out of making it. So this particular machine I use is made in Germany. It's out there. I called Germany to find where I can find this machine, and there's still a couple of companies that have these machines around.
You know who would be a good group to, not just the general medical staff, to give the lecture about these different treatments, but also the emergency room docs. They see this stuff all the time.
Sure.
You know, they see people with heel spurs and fungus nails, and they just give them topicals and send them home. You know, people end up there. I mean, it's really sad that we don't know that. I didn't know half of it. I knew what they were, but I didn't know all the treatments. So thank you for educating me on this. And then another one that you know I knew about or heard about was resurfacing and joint preservation. I have no idea what that is. Resurfacing what? What's that mean?
So what you're referring to is a procedure I do that has to deal with arthritic bunions. So a bunion, again, is a misalignment of the big toe joint. There's certain bunions that are not so misaligned, they're just arthritic. So the bone looks like 3 times the size on the big toe joint. It doesn't move very well because it's arthritic. This could happen very often from poor function. The bone could be elevated and jamming over many years and causing arthritis, or it could be traumatic, in which they get a bone chip. A lot of people have injuries that they don't treat or never gets properly diagnosed. So if you have a fracture in a joint, for instance, and it's not diagnosed or immobilized, let me just add this because I'm on the subject. I just want to share this with the local community here. The most common misnomer is that you cannot treat a fractured toe. And now they'll say that in the ER still. It just baffles me because if you have a fracture of a toe and you don't treat it and the fracture extends into the joint, I guarantee you a bone spur and arthritic joint, and you'll come see me for surgery the following year. So yes, treat the toes. They need to be immobilized.
So that's when they tape your 2 toes together.
Yeah, that's called buddy taping. The problem is buddy taping doesn't work. That's not how you immobilize a toe. If you ever look at the anatomy and look at an X-ray, your toe extends well beyond the web space of the interspace between the toes. And if you're not wrapping the toes to the rest of the foot, unless you're fracturing the tip of the toe, which is much more rare, but the most common fracture is the first bone, about at the base of the toe, and you can't buddy tape it. It's not going to work. In fact, it can make it worse.
Well, another lecture for ER.
There you go.
Because I always thought that, I always heard that, you know, when you got a fracture there, you just tape that thing together, you know, and supposedly it straightens it out, but it doesn't do that.
No, and then what you were referring to, we're dealing with the large toe joint, so that's really going to cause you problems. If you go to a surgeon to correct this, I would say 9 out of 10, and it's not wrong. It's the standard procedure, which is a fusion, where you actually use a bone plate and screws and fuse the joints together and get rid of all the excess bone. The issue with that is that toe will never move again. And your body will accommodate for that as long as the other joints at the end of the toe and in the middle of the foot is good. You'll function fine, but the deal is that it's going to take 4 to 6 weeks for that bone to heal. You have to be immobilized. And especially for women who want to wear a heel, you won't be, you can maybe get up to an inch if the procedure is well done. So there are limitations for the person with the fusion. And this toe resurfacing you're talking about is actually an implant. And the implant can be used to resurface the joint instead of fusing the joint. And that procedure would allow the patient to walk immediately and maintain the motion.
Tell me what resurfacing, what it does. I mean, you mentioned it. Explain. I don't understand the resurfacing part so much.
So when you
I got the screws and all that, that part down.
When you have an arthritic joint, what's happening is you're losing the articular cartilage, which is the cartilage which allows the joint to function pain-free and smoothly. In an arthritic joint, the long bone, which is called the metatarsal, that head of that metatarsal is the first to lose the articular cartilage. That articulates with the base of the big toe, which can also get arthritic. So this toe resurfacing does have what we call a total implant when you have to resurface both the base of the toe and the metatarsal. But they also have a hemi, which I use very commonly because the most damage typically is to that long bone. And instead of fusing, we do this toe resurfacing, which is what we call it's an arthrosurface hemicap. For those that may be looking it up, it's also on my website. But the beauty of this is it's the first implant that I had seen that didn't have a stem that had to heal, and even most implants, you have to be off your foot for the stem of the implant to incorporate with the bone. The difference with this particular procedure is there's a screw component. There's a screw that goes in the bone first, and then there's an interlocking implant. So this toe resurfacing is actually an implant.
So you're not fusing the joint with screws.
We're not fusing not in this procedure. We're putting a screw into the bone, and that has an interlocking connector with the implant. So once that snaps in, that implant's not going anywhere, and you can actually walk immediately.
Okay, and they can wear heels again, women?
And they can wear heels.
Oh, that's good. So that's another thing that I think good to know. You can get up on your toes, more or less.
And you're not burning any bridges. If it needs an implant anytime in the future, a lot of times with implants, you have to remove so much bone. It's very difficult to do something else later. So this could buy, undeterminable number of years, but you may never need anything again, or at some point you may need something else, but it definitely buys you time.
So it's sort of like a partial knee. You do one side of the knee, and then you got arthritic knee, but all of a sudden you got one pocket on this side, and the other side's supposed to be okay. I don't know. And then you have that done, and then a few years later you got to have a total knee done.
Yeah, well, like I said, they have a total implant for this as well, the total resurfacing implant. Where you're not using the stems, you're actually just screwing in the resurfacing portion of the implant. So it's a lot less work, but very comparable to a knee. It's a great analogy.
So what is your website again?
It's tobackpodiatry.com, and our phone number is 845-339-3338, which is 339 feet.
That's pretty good. I was just thinking, of all the things we talked about. I find the laser, for the fungus, for me, the one that's like magic. And I think, when I was reading about it, and I see the toe grow out, and I also was able to pick up some videos on the surgery and stuff, and on the treatment rather, and you can see how it's done. And then and you also can hear some of the people say, like, I never thought my toe would look like that again.
Yeah, no, it's a great procedure. It's a totally painless procedure too, so it's very easy for the patient. There's no anesthesia for it, but fungus is tricky. Like I said, it's not going to be 100% because of the damage of the nail bed, cosmetically especially. But it's super effective at killing that fungus. So it's like I said, if it wasn't for the out-of-pocket costs, I would be doing that on everybody.
I know that you're good at this, but when patients come in and they don't have insurance, do you have programs for them? We have these I don't know what they call it, care credit or something like that, and they can get on those.
Yeah, we have care credit, through our office. We offer it all the time. It's it's very easy to get. Most people are in the treatment chair, and I come back and they go, I just called care credit. We're ready to go. So it's very easy to get. It's care credit, for those that don't know. It's typically some instant credit you get for medical bills. It allows. I know when my dog needed emergency surgery, they came to care credit.
Is that right?
$3,000. I'm like, sign me up. So it comes in really handy for medical expenses, and it gives patients amount of time to pay it off without any interest.
They have a payment program. We use it also. I didn't know about the dog part though.
Yeah, vets use it.
Everybody gets to use it. So that's interesting. So the shock treatment, shockwave treatment, warts and funguses. What do you think, Dan?
I think we've been schooled, Ed.
As opposed to
Thank
school.
you very much.
It was,
Sure
it was,
thing,
it
my
was
pleasure.
pretty good, huh?
Yeah, absolutely.
Well, I learned a lot. I appreciate that. Any parting words? I know you have to go. You have surgery this morning. Anything else?
No, I invite people to look at the website, because I just find people think that a podiatrist is here to shave down some calluses and cut some nails, but there's a lot more to it. And your foot is, to me, the most important part of your body, because without your feet, you're not getting around too quickly. And it's also the foundation of your body. So a lot of other issues, including lower back pain, very often is coming from the foot. And I've taken care of a lot of back pain, unbeknownst that I was even treating the back. But once I corrected the foot, they changed their whole lifestyle. So.
I just got a text message that said, Dr. Toback's really good. You should bring him back. I just saw that in a text. One more thing was nails, cutting nails. I know that diabetics have to have their nails cut uniformly and appropriately because of the small vessel blood supply and what could happen to them. I know you mentioned nail cutting, made me think of it. Like that's not the only thing we do. You trim nails. Damn. I'm sorry. That was supposed to be off. Calling in again. Call the wrong number. So what, do you have to take care of cutting nails? My brother used to get ingrown toenails. He used to cut his nails wrong, I guess, and they would grow in. Just one final thing on cutting nails. Trimming nails.
It is super important. I would say, that's still a big part of my day is what we call palliative foot care, and that's to take care of those things, because that's usually, and unfortunately for diabetics, when you talk about limb threatening, and losing a leg, and then potentially losing two legs and losing a life, I can't tell you how many documented cases it all started from a toenail, infected toenail that got out of control and became gangrenous before they got any help. So and I encourage most primary physicians already do this, but I encourage all primary physicians to do this. And anytime they're having a diabetic patient in their office for an exam, take their shoes off. I had many primary physicians tell me they do this all the time, because you don't know what hidden surprises are in there. I had one patient come to me because her daughter-in-law saw her in the kitchen with barefoot, and she basically screamed. The big toenail was going into the fourth toe was going into the big toe. I've had that on several occasions.
Long?
Yeah. I cut one person's toenails, and she fell out of her shoes because she just kept buying bigger shoes, and she had no shoes to go home with because she couldn't wear them. It just fell off. But on a sadder note, I had another one that was already gangrenous, and she ended up losing the leg, all because of the toenails that weren't treated. So it gets kind of crazy. But infections of the toenails should be treated too. One quick story was a young girl, probably 19 years old, had two badly infected toenails. You do get something called a granuloma, which is a foreign body reaction when the nail digs in. and hers got so large that she assumed she had cancer and didn't want to tell anybody. Unfortunately, she waited a year, so what happened was her bones were infected. It was so bad. We had to get her IV antibiotics for about 6 weeks, but we got the bone infection healed. She did okay, but it was just so unnecessary. But I had another gentleman who had a non-healing granuloma, and doctor only prescribed antibiotics. And by the time he came to me, it was I diagnosed squamous cell carcinoma, and he ended up losing the big part of the foot there.
Yeah, well, I think when people, my theory is when you have something that persists, you probably should pursue. Even if you went one place and it continues on, you need to pursue further and longer to mediate and stop that problem from reoccurring or continuing to occur. Dr. Toback, thank you.
It's my pleasure.
Great job.
All right, thank you, Dr. Aleo. I appreciate the time.
And we'll bring you back.
Beautiful.
Okay.
I look forward to it. Take care.
We've had some really good people over the last year or so come in and tell us about their specialties. Dr. Toback was outstanding with all the different areas that you never think about that they treat. Not only do they cut your toenail for certain people, they think that's what they do. I remember years ago, I think it was back in the 80s, they didn't have privileges in the operating room. So they had to work hard at that. But because of the orthopedic guys in town, they really worked hard at doing a unified approach. And now they work closely together with ankles and toes, and they even do joint surgeries together now. So it's a real collaborative, collegial
Well, that's interesting
thing,
to know.
that I don't think people know. Not everybody gets privileges in hospitals, and these guys are real surgeons, and they have a program for residents that come from the different podiatry schools here, and some of these guys all have residents within their practice.
Well, I think it's
It's pretty interesting.
It's phenomenal, and every time I've ever spoken to a podiatrist, with or without any need for myself, friends that are a podiatrist that I've had, I'm always amazed and fascinated by the breadth and the spectrum of what is doable and what's repairable, what's treatable, what people so generally, as Dr. Toback said, people let them go for too long and don't have to suffer it.
Well, nothing worse than having a sore foot, I guess, or a big toe problem. Anyhow, moving along, I'm going to talk a little bit about hearing. Is that okay, Dan? Okay. I was thinking when I was talking to Dr. Toback, about the balance system in general. And, as I said, we think of the balance system as being like a three-legged stool. And to that end, the three legs of the stool are your eyes, your ears, and your proprioception. Proprioception is really the lower part of your brain called cerebellar that allows you to know where your body is in space. That means that, if you put your arm out or if you put your fingers together, they're going to touch each other when you close your eyes. And if you close your eyes and you miss by a lot, that tells you that you're not, maybe the back of your head, your brain isn't that good. So when you do it, you put your fingertips like this and you do this kind of thing. And that means that but if you miss, that tells me that you have a little problem with that. And the other thing that happens with proprioception is, like, a perfect one is if you sit in a chair and you go to sit down and the chair is there, we sit down, we don't think about it. But if the chair is lower than usual, we hesitate. Or a perfect example would be a toilet seat. If you sit down in a toilet seat and all of a sudden if the seat is up, as you're going down, you know it before you hit. And so when people know where they are in space, or if you pull a chair out from under them as they're sitting down, they immediately know as they're going down, their body tells them that they missed the chair.
So you react. Yeah,
That's your
you react.
proprioception. So proprioception becomes important, like if you're on a boat, for example, and it's moving. You're moving, and the waves are going up and down, and your body, and you're walking, and you can feel yourself moving. That's proprioception. You know where you are, and you stabilize yourself. So when you have a balance problem from your ear, for example, which is your ear has two parts to it: your balance part and your hearing part. One is the vestibular system, and the other one is the cochlear system. The cochlea is the hearing part. The vestibular is the balance part. Remember the old semicircular canals? So that's the balance part. And they're really tiny, but they go together. So when you have a problem with one, oftentimes you have a problem with both. And people don't think about that. So when they have hearing loss, they think they have hearing loss.
One incredibly intriguing question is, how did we evolve? You probably have some perceptions about this, some research about it. How did we evolve so that the semicircular canals, the vestibular, is so close to the acoustic, the cochlear? Why are they so integrated and ingrained? Couldn't the balance part of our body have been have evolved in another place in our bodies?
Well, I guess it could have, but it didn't. It works like this. Like I say, you have two balance systems. You have your brain, which is the cerebellar part, and that's a big balance system. The other one is your ear. Well, in the ear, you have the nerves. You have two nerves, a branch. One, it's called the eighth nerve or the cochlear nerve, but it's really the eighth nerve, and it has two branches. One goes to your hearing part, and one goes to your balance part. And in like our balance system, again, righting ourselves, keeping ourselves, level, is different than like a cat. A cat has a different kind of a balance system. It's the same one. I mean, it's there together, but theirs is definitely a much better righting reflex. So you ever see a cat? If you take a cat and it was to fall off of something, they always land on their feet. They can jump off of a tall, one-story building and land on their feet. And if they don't, they're in trouble. That means they got a bad balance system, which happens. But so I don't know why they're together, Dan. I can't answer that question. My embryology is lacking right now.
I'm starting to get it.
development.
I mean, acoustically, we notice a whole lot of our spatiality. The way we understand the space we're in happens acoustically too.
Well,
with our, like with
that's
all the differential between your left and right ear.
That's an interesting thing. And that's why they're together, in the sense that you have from your cochlea to your brain, we go through different steps, like the cochlear nuclei, or the inferior colliculus. Those all sound like really nice words. Or the medial geniculate body. And at one of those steps up is a localization process that goes on. So when sound comes to us, it helps us know where we are in space, again, because we know that if a sound comes from our right side, how do we know it's from the right side? Well, the way you know is it goes into your right ear, and then it goes past your nose to the other side. Well, that's a time delay. And then your other ear hears it. Well, it isn't like it goes really slow. It's instantaneous. Or it'll bounce off the wall, and you know that you got to look right. And the other thing you do, it has a up and down system. You know that it's down here or up there. And if you have a hearing loss, people with hearing loss can't always tell where sound's coming from. And especially if it's a different hearing loss between the ears, then they definitely don't know where sound's coming from. And so you got up and down, you got right and left, and you got front and back. And that all comes from those stations or pathways in your brain from your cochlea. So that's why they're integrated somewhat with your balance system. How's that, Dan?
I think we're nailing it.
Yeah, I think we
we're
nailed a
nailing
good
it.
one.
Yeah.
We have to tell Dr. Toback we nailed it. Anyhow, well, that was bad. It's interesting that people who have a vestibular problem, your ear problem, have vertigo. Now, dizziness doesn't mean vertigo. Dizziness can be in a generic term. It could be, I feel lightheaded, I don't feel normal, I feel spacey, or the room is spinning. Vertigo is a motion thing. So the room is spinning, or when I turn, I feel unsteady, or if I roll over in bed, the room spins, and also comes with that, oftentimes, is vomiting. When people have vertigo, they vomit. So another extension of that is, people who drink, get drunk. And you work in a restaurant, so when they drink too much, what you do is you do two things. You not only sedate your brain, the cerebellar part, but you also affect your balance system in your ear. So and people have spinning. Spinning is the ear. Walking, unstable, is your brain. So you got two things going. That's why they fall down, literally. Falling down drunk. And so what happens is the person with the ear problem. It's hard to say this, but you have this other system going from your ear to your stomach. It's your vagus nerve, and that's how they vomit. So when you get dizzy, people get sick. When you're drunk, they get sick. So either way, for the people who drink too much, and those people have intermittent dizziness, episodic dizziness, who are vertiginous dizziness, when you get dizzy, the first thing people want to do is close their eyes. That's the first thing you don't want to do. You want to keep your eyes open, and you want to look at something. Like I always say, put your thumb up in front of you and stare at it, or stare at something on the wall, and that'll help slow down the dizziness. If people who become car sick have the same problem. Their ear is a problem, and now their proprioception is off because they're riding in the car. So they're not stable. So what happens is, remember I told you about the people who had the little Petty Mall thing by the streets, the trees going by and the sun coming up or going down.
Yeah, that certain frequency
they would
of light.
zone out. Well, the same thing happens with people who are in cars, and they look at telephone poles going by. Or they look at the road and they see the divided line in the road, and they get sick. Or they're riding the back seat of the car. The people who get car sick should always be in the front seat, and they know that instinctively, that they want to sit in the front of the car, not in the back. Because when they're back, they can't see. They're locked in. And now, because of their body, proprioception, and their bad ear, they got a weak vestibular system, they get sick.
It's because you don't have control over your environment, and you don't have any perception of where your environment is. So being in the front of the bus or the car, as opposed to the back where you can't see anything and you don't have a sense of space and perception of where you're going and where the horizon is. Same thing happens on a boat. The worst thing in the world is to go down in the cabin.
Yeah. So what you want to do is you want to look at something straight ahead. Mm-hmm. You want to look at something down the road, but not at the broken lines in the road. You don't want to look at those.
Right, yeah.
You want to look at down the road, or look at a car ahead of you and just do that. Otherwise, and you can see the same thing when you watch TV, and you'll see, a wheel of a car, and you notice this is the fundamental frequency thing again, and that's what happens with your ear when things go clicking along, and your weak vestibular system, you get sick. That's the fundamental frequency. So, and then when people are getting that stuff's clicking by, that's what makes them sick. So that's the interesting part. You can seek out what makes you respond vestibularly, and that's the vertigo part. So that's the balance system. So there's three things to the balance system. If your ear is bad, you have a weak ear, So you have vertigo. So at nighttime, you want to keep a light on in your bathroom, like if your bathroom's right there, or a night light. So when you get up and it's dark, that's when you get dizzy. So if you have a light on, you get up, you see the light, you look at the light, and that helps stabilize you because that's the other third leg. Your eye, your ear, and your proprioception, or the base of your brain, the cerebellar part. In the cerebellar part, that's the person who is walking along and they shuffle their feet. Their feet. They don't pick their feet up to walk. They kind of like slide on the carpet or the rug, and they'll on the floor. They'll move their feet, but they won't pick them up. So they look like they're shuffling, and that's because if they pick their feet up, they become unstable. So the important thing for a lot of people who are older people who really probably they don't need a walker, but they need a cane. You don't need a four-legged cane. You need a little simple cane, a cute cane even. You can buy it at the drugstore, and we call that a third leg to the ground. You just put the thing down and touch the ground as you're walking. Did you ever notice people older people who hang on to their husband or their wife or their child when they're walking? That's a cerebellar problem. So if they had a cane, they could walk along and just touch the ground with the cane, and that gives them stability. Or they'll walk along and they'll touch the wall as they walk. That's what handrails are for. And the other thing, the worst thing you can do in an office situation with patients is to have really nice thick carpet. They can't stand up on it. Yeah, because they lose their proprioception. When you step down on it, they're like, it's sort of like they can't slide or glide on it. Mm-hmm. Where you have close carpet on the floor, like all-weather carpet, you can kind of go along and it's okay because it's hard.
How's our carpet here for a doctor's office?
This is cool.
This is good one.
This is cheap carpet that works well. No.
It's worked very well all along.
Yeah, you won't fall on this one. But when you have plush carpet, which really looks good, but it makes them very difficult. I learned that early on in my career. I had a really nice carpet in my office. I had to take it up because my patients couldn't walk on it. They became unsteady. So I think that's an interesting little thing to know. So if you're going to buy carpet and you have an older family member, maybe you don't want to get too plush of a carpet if you want them to come and visit you and stay upright. So anyhow, that's the balance system. But so the balance system works well. So you have it, in your ear helps your balance system, and your hearing helps your balance system. So as you increase the hearing loss, it means it gets worse. Oftentimes the balance system becomes less effective and less stable. People become less stable, and I don't think people see that too often. They don't realize that's what happens. So, matter of fact, as you increase hearing loss, and since it affects balance system, guess what happens? You have more people who fall. You have more falls. And we were talking about fall assessment. So maybe part of the fall assessment is to do, like I said, we do that walking in place we're talking about with eyes closed, but you also have to do a hearing test. And if the person has a significant hearing loss, and you do walking in place, now you know that they are at risk to fall. So somebody said to me, well, if you put a hearing aid on somebody, will that help them not fall? No, it does. They don't. What happens when you have hearing aids on somebody with significant loss who also have a balance problem, the thing that happens is they know right from left, up and down, and they can localize better. And that helps the fall situation indirectly. But we put a hearing aid on somebody doesn't stop them from falling. But people like to say it does, but it doesn't. So, hearing aids are really effective in localizing because people who have mild to moderate hearing loss have a little bit of a balance problem. So it starts out gradually, and it becomes a problem. But hearing aids are really smart these days in the sense that we have one hearing aid. Ready for this? Let's say you have a significant hearing loss, and the hearing aid, you can turn on the program so that if the person not only can hear better, not with the hearing aid can not only hear better, but if they were to fall, it has this geochron thing where if it accelerator, so when they fall quickly to the ground, it notifies a significant other. How's that? Your hearing aid notifies somebody that you fell down.
That sounds great. Sounds like it should be part of the app for the hearing aids, and that's kind of where hearing aids are. Is you have a lot of devices and control with your maybe iPhone or something like that, and the app that goes with it is very, very versatile and very helpful for you as a doctor and for the patient as well. Am I correct?
Yeah, yeah. Matter of fact, it is an app on the phone. And there's only one lab right now. Matter of fact, it's called Starkey, and they have on all levels of the hearing aid. We have hearing aids that are high-end hearing aids, and we have introductory hearing aids. And I think that in all of their different levels of hearing aids, they have a fall protection on it. How's that? But you got to turn it on. It doesn't matter if you don't turn it on, right? So, hearing aids are not what people think anymore. Everybody thinks that the hearing aid is this cord coming down from your ear like their grandfather had 50 years ago. And they all think that hearing aids don't look good, but if you look around, everybody's got something sticking out of their ear anyhow. And hearing aids are not as intrusive looking as some of the buds you see in people's ears.
Exactly. Obviously, there's some hearing aids that you don't even know they're there.
Oh yeah, most of them you don't know they're there. And people go like, well, I have this buddy of mine who says, well, I don't. He can't hear for squat. That's a good word, squat. It means he can't hear well. And so what he does is he doesn't want to wear hearing aids. And I said, why not? He says, I don't want people to see it. They'll think I'm old. I said, they already know you have. I said, the hearing aid, your hearing loss is more noticeable than your hearing aid. I says, and they know you can't hear when they talk to you. I said, so what the heck, man? You need to do something. And sometimes you don't, I used to tell patients, sometimes you wear hearing aids for educational reasons, for business, and for family. And when it comes to family, if you want to participate and you can't hear, you don't participate. And those people tend to withdraw and become more isolated. And even at mild hearing losses, they go to a restaurant and they have a high-pitched hearing loss, which is a high-frequency hearing loss. They don't hear in background noise. When there's background noise, they're terrible. So they don't go out. They start staying home. And high-frequency hearing loss or high-pitch hearing loss affects clearness. And by clearness, I mean consonant sounds. So if any listeners are out there, if anyone wants to try this, and you can try it yourself, Dan, sometime, write a sentence out, and then take the sentence and take all the vowels out of the sentence, and you can still read the sentence. Vowels are low frequency.
Yeah, the opposite is not true, though.
Yeah.
If you
so if
just
you take
leave
the
the
consonants
vowels
out, or you malalign the consonants, or make part of the, like an H, and take off the little hook off the H and make it like an L, and you put that across, they can read part of it depending how much of the consonant you take off. That'd be a picture of a hearing loss, a high-frequency hearing loss.
That's very true.
Yeah.
And, there are some languages throughout the world that just use consonants.
Right.
Hebrew,
right.
for one.
Yeah.
Hebrew, for one, is just consonants. The inflection of the vowels in between the consonants is well known, is a given once you know the word, so that it's not written, which is fascinating.
So if you take somebody who has a really big hearing loss, like a quasi-profound hearing loss, basically all they have are vowel sounds. Vowels are loudness. Consonants are clearness. So high-frequency hearing loss is a consonant problem, and big severe hearing losses, or deafness, or profound hearing losses, is a definite consonant problem, but all they hear is the vowels. If you only see vowels in a sentence, you can't read anything. So if you only have low frequency and a big hearing loss, The only thing the left is low frequency. You don't hear what's going on. You don't understand what's going on around you. And in all situations, whether you have a mild or even a moderate, a high frequency loss, or even a low frequency loss like children have when they have ear problems, they have low pitch problems, background noise is the enemy for all of them. So children in school who have stuffy ears or allergies and are transient, they come and go, cause reading problems for children, but they also look like they're not paying attention because they're bored, or they can't hear. And if you can't hear, if you have a consonant high, if you have a low frequency problem, which are vowels, and the first thing we used to learn is how to read, you start out with A, E, I, O, U. And if you can't hear the vowel sounds and you want to read and you try to blend with consonants, they have reading problems. How's that? So years ago, we did a study on children, and from kindergarten through second grade, it didn't matter what time of the year, because I think it's, a different seasons cause different problems, and it's true, but during any time of the year, 25% of the kids had stuffy ears. Didn't matter when. And the only way to find out is to do this test called tympanometry, which measures the eardrum and the bones behind the ear for stuffiness, not the hearing test. You beep, beep, raise your hand. You're telling a 7-year-old to respond to a hearing test, they're going like, when? Okay, I want to please you, so do I respond when I just hear it? Which they never do, so they respond when it's comfortable. I can hear that, and they pass the test. Or the test is given at such a loud level, it's called 25 dB or 25 points, which is more than a stuffy ear would be. So they pass and they still have a hearing loss. So they still have intermittent middle ear problems that people don't think about. And so they go. So the only test for children, the best test for kids, is called tympanometry. If they fail that, they have a transient, only temporary, don't get excited, temporary transient reduction in hearing. We don't even call it a hearing loss, reduction in hearing, but it could affect when they're little, it affects their speech development, or they have speech delay. When they're first grade, it affects their reading ability. So on that note, watch out for your kids and do tympanometry. Was that good?
It's always fascinating. Sound, again, is something that you don't see, so to give some flesh on the bones, so to speak, is very, very good, because sound is something that's mysterious to most people. Yes,
I agree.
Yeah. Okay. Thank you, Dr. Ed Aleo.
Thank you, Dan. Take care of yourself, folks.
Absolutely.